In this video, we'll do neuroanatomy and neurophysiology of the midbrain. Thalamus and hypothalamus or diencephalons are above the midbrain, and caudally it has hindbrain, pons, medulla, and cerebellum. So this is the cut section of the midbrain, and the parts of the midbrain are superior and inferior coliculi, superior and inferior cerebral peduncles, tegmentum, cerebral aqueduct, and tectum. So this black circle is cerebral of aqueduct, and a gray matter around this is periaqueductal gray matter. I put a red line, and a portion behind that is tectum, and part in front of that is tegmentum. So tectum is the posterior most or the roof part, and tegmentum is the centrally located biggest part of the midbrain, and cerebral peduncles are placed anteriorly. In the middle it's substantia nigra, and these are the nuclei: third nerve nucleus, the Edinger Westphal nucleus, the parasympathetic nucleus, and the general somatic efferent nucleus that controls the extraocular muscle, and these are the cranial nerve 3 oculomotor nerve fascicles. Fascicles are the fibers of the oculomotor nerve. They arise from the nucleus up to the interpeduncular space. So the fibers that arise from the Edinger Westphal nucleus are parasympathetic. So the parts of the midbrain from ventral to dorsal are cerebral peduncle, tegmentum, and tectum. Tegmentum in front of the cerebral aqueduct and tectum behind. The cerebral peduncle is superior to the pons. And what do they contain? They have corticospinal tract in the middle 3/5. The fiber arrangement from medial to lateral side are arm, face, and legs. So number 1, they have corticospinal tract. Number 2, they have corticobulbar tract, and number 3, they have corticocerebellar tracts. So corticospinal tract occupying 3/5 of the cerebral peduncles, and a lesion of the corticospinal tract which coming from the internal capsule causes contralateral spastic hemiparesis. Whereas a lesion of the corticobulbar tract, what does it cause? It causes contralateral weakness of the lower face because of the involvement of the 7th cranial nerve, facial nerve, palate, which is supplied by the 10th cranial nerve, and the tongue, which is supplied by the 12th cranial nerve, hypoglossal nerve. Tongue deviates to the weak side when it's protruded out if there is a lesion of the corticobulbar fibers. So the nuclei of the midbrain are colliculi, superior and inferior coliculi, red nucleus, and substantia nigra. So what's the function of superior and inferior colliculus? The superior colliculus processes visual information and are involved with saccadic eye movement, and the tectospinal tract connects the superior colliculi to the cervical nerves of the neck to coordinate head and eye movement. And number 3, each superior colliculus also sends information to the corresponding lateral geniculate body of the thalamus. So I summarize superior colliculus functions. Number 1, visual information and saccadic eye movements. Defect causes paralysis of the upward and downward gaze, and number 2, there is absence of convergence, and then tectospinal tract coordinates head and eye movement, and number 3, it's connected to lateral geniculate body of the thalamus. Now inferior colliculus, it's located just above the trochlear nerve, and it processes certain auditory informations, send information to the corresponding medial geniculate body of the thalamus. So I summarize: the inferior colliculus process auditory information and is connected to the medial geniculate body of the thalamus, and its disorder causes tinnitus and hyperacusis. So superior colliculus is concerned with vision and it connected to the lateral geniculate body, and inferior colliculus is concerned with auditory informations and connected to the medial geniculate body, and lesion causes tinnitus and hyperacusis. Whereas a lesion of the superior colliculus causes paralysis of upwards and downward gaze and absence of conversion. And now visual, auditory, and eye movement pathway. We'll discuss here the oculomotor nerve. Cranial nerve which arise from the midbrain are oculomotor nerve and the trochlear nerve. Oculomotor supplies the extraocular and intraocular muscles except for the superior oblique, which is supplied by the trochlear, and lateral rectus, which is supplied by the 6th cranial nerve. The oculomotor nerve nucleus is located at the ventral side of the tegmentum. So this is the oculomotor nerve nuclei. It has two types of nuclei, general visceral efferent and general somatic efferent. The general somatic efferent nucleus is in front of the periaqueductal gray matter, and it supplies the extraocular muscle except superior oblique, which is supplied by the fourth cranial nerve, the trochlear nerve, and the lateral rectus, which is supplied by the sixth cranial nerve, the abducens nerve. And these are the fascicles of the nerve which arise from the nucleus. And the second nucleus is the parasympathetic nucleus. It's known as Edinger Westphal nucleus, and it's in the periaqueductal gray matter. So these nuclei arise from the tegmentum in the front part, from the front of the ventral midbrain, whereas trochlear nerve arises from the dorsal midbrain. So the GVE, general visceral efferent nucleus, supplies the intraocular muscles and causes pupillary constriction. It supplies the pupilloconstrictor muscles and the ciliary muscle. These fibers relay in the ciliary ganglion, and short ciliary nerve supply the constrictor pupillae and ciliary muscles. So the parasympathetic supplies the pupillary constriction. And what's the nerve supply of the dilator pupillae? The long ciliary nerve from the superior cervical sympathetic ganglion supplies the dilator pupillae. So constrictor pupillae supplied by the parasympathetic fibers and dilator pupillae supplied by the sympathetic fiber. And the pupil is dilated and fixed in third nerve palsy. So why is it so? Pupil is dilated in CN3 palsy due to unopposed action of the dilator pupillae, which are supplied by the cervical sympathetic ganglia. And pupil is fixed. Why? Due to the loss of pupillary light reflex. Why? Because cranial nerve 3, oculomotor nerve, forms the efferent limb of the pupillary reflex pathway. Now, oculomotor nerve lesions in the midbrain stroke. The oculomotor nerve nucleus or its fascicles are damaged in the anterior midbrain lesions. The effects depend on the location of the lesion. Lesion of the rostral midbrain causes bilateral ptosis. Why? Because levator palpebrae superioris, which is also supplied by the oculomotor nerve, is supplied by the single central subnucleus with weakness of the contralateral superior rectus muscle. So if the lesion is in a nucleus, it causes ptosis along with the contralateral weakness of the superior rectus. As I already mentioned, fascicles are the portion of the nerve fibers from the nucleus to the interpeduncular space. The lesions of the fascicle cause ipsilateral weakness of the superior inferior rectus, medial rectus, and inferior oblique muscle which it supplies. So the results of ipsilateral oculomotor palsy are dilated pupil, diplopia, and drooping of the lip. And what's the position of the eye in the third nerve palsy? Eye is turned down and out. Why? Because of the unopposed actions of the lateral rectus and superior oblique muscle. Now the trochlear nerve arises from the dorsal midbrain just below the inferior coliculus. Trochlear nerve is the only one that arises from the dorsal side of the brain and is the smallest cranial nerve. Now blood supply of the midbrain. Midbrain is primarily supplied by the posterior cerebral circulation, including basilar, superior cerebellar, and posterior cerebral arteries. So what's posterior cerebral circulation? Posterior cerebral circulation arises from vertebral artery. The vertebral artery on the right side originates from the innominate artery and on the left side from the subclavian artery. So it's an innominate artery from which vertebral arising on the right side, and on the left side it arises from the subclavian artery. So this is left subclavian and vertebral arising from this. And how it enters the brain? It passes through the upper 6 cervical foramina and enters the cranial cavity through the foramen magnum and unites with the other vertebral artery at the lower border of the pons to form the basilar artery. So this is the basilar artery, and then this basilar artery terminates at the pons and midbrain junction by bifurcating into the posterior cerebral artery. So vertebral arteries forming basilar artery that divides into posterior cerebral arteries at the midbrain pons junction. The posterior cerebral artery in 75% of cases arises from the basilar artery. In 20% of cases, posterior cerebral artery arises from the ipsilateral internal carotid artery. The medial zone of the midbrain is supplied by the paramedian branches of the basilar and posterior cerebral arteries, and the lateral zone is supplied by the branches of the posterior cerebral artery. Superior cerebellar artery supplies the caudal midbrain and lateral rostral pons. The penetrating branches of the posterior cerebral artery supply the rostral midbrain. So this is the blood supply of the midbrain, which is divided into medial zone and the lateral zones. Medial by the paramedian and posterior cerebral, and whereas caudal is supplied by the superior cerebellar artery, and the rostral part is supplied by the penetrating branch of the posterior cerebral artery. A compromise in the paramedian branches of either the basilar or posterior cerebral artery results in infarction of the oculomotor nucleus and or its fiber, in addition to the cerebral peduncles. The superior colliculus and tectum are supplied by the superior cerebellar artery. The damage to the posterior cerebral artery that supplies the midbrain may cause Claude and Weber syndrome. We'll discuss them when we discuss the midbrain syndrome.